historically, it's a diagnosis that clinicians run from. It has, a lot of typecasting or labeling that's done. They can be very challenging, difficult patients. They can be manipulative. But at the same time, if you have some skills and you understand what their weaknesses or what their fragility really is, it can be quite easy to treat, especially initially. And again, I'm talking more about the high-functioning borderline patient or the patient who has traits of borderline personality disorder. Like all other diagnoses and disorders, there's a continuum. Mm-hmm. We all have a little bit of this stuff in us, right? As we do, pretty much every diagnosis in the book. But, for the borderline itself, it's on a pretty broad continuum. So the label of borderline is given far too easily, in my opinion. It's issued greatly. When I used to work in the New York hospital system, pretty much any female patient who was difficult to work with would be labeled as, she's a borderline. And I think that's, a problem in the community. And I think it's being addressed to some degree. I think there's, there have been some changes. But, at the same time, I think the clinician that understands how fragile the borderline patient feels, who understands, that it's based on faulty thinking and a faulty narrative about themselves, and can equip them with some of the tools they need, and who has, enough empathy and patience to understand that it's a process, Sometimes I see great progress in a month, sometimes it takes a couple years. Sometimes I hear the same story week after week for a couple of years from a patient. I don't get frustrated with that. I understand that's their process. It's like recovery. Don't know how many times it's going to take, as long as someone's working towards getting there. What we see a lot of in this practice, and quite frankly, it's probably more than 50% of my clientele or my patients, are people who present with depression or anxiety, and soon enough we come to understand that the depression or anxiety and mood swings is related to relationship letdowns and disappointments. So really, you can almost call the high-functioning borderline or the person with the borderline personality traits someone who has relationship anxiety, because that's kind of what it might look like. And what you'll see, and what I point out to people frequently, is you'll see urgency, desperation, impulsivity, an inability to self-soothe, dangerous choices for self-soothing. And really what underlies the whole disorder is, basically a fear of abandonment and rejection. And the irony is, the behaviors that come out when someone fears rejection, real or imagined, is what threatens their existence in the relationship. It's not the relationship itself or their interpretations. The engagement process is so important, and the duration of that process varies. Sometimes I feel like I can engage a patient in 2 sessions. They just are amazed that someone understands everything they're going through even before they can describe it, and then there's a trust there. The first thing I like to do is to let them know that I really understand their symptoms. So occasionally when I meet a new patient, before they tell me their story, I'll try to tell them their story. I'll try to tell them that I understand that they feel urgency, impulsivity, an emptiness inside, that their mood switches frequently from anxious to dysphoric to okay, that it hinges very quickly on their intimate relationships, that they have a tendency to idealize people and then soon after devalue them. And sometimes I'll even go as far as to describe most likely what their family constellation looked like, in the sense of how, what it looked like for them growing up. Because, there's a lot of questions about this disorder and the derivations, and certainly there's a genetic component, but in my experience, and it's with hundreds of patients at least, there's also a family cluster that tends to be there, which, tends to look like a father who is usually absent, whether emotionally or physically, and a mother who, during the early years, the first 2 years of life especially, is unable to take care of the child or soothe the child or resents the child or is in competition with the child or is suffering from her own depression or her own issues. So that, that tends to be the derivation. The thing I do is, I'll let a patient know that I really am in such a privileged position of objectivity. I don't benefit from them getting better or worse. I don't benefit from lying to them. I'm not trying to sell them anything. And I think that gets through to people. So then they're able to hear from me in an objective way and realize that, my criticism is not an attack. Frequently patients will say thank you for a compliment, and I'll say that's not a compliment, it's an observation. So the engagement process, varies in time, but getting them to understand that they're understood, getting them to know that your intentions are to take care of them. And so the technique is to engage the person, get them to trust me, and for them to understand that I know all too well what they're going through. At which point, I start to confront someone, confront them on their behaviors. And that's, calling them on their responsibility in the situations, what they did, taking them out of that victim role. So, obviously it's pretty important that the confrontation phase doesn't come too soon, but, a good clinician will know when a patient's ready to hear certain things. What patients have to understand when they do at a certain point is that, feelings aren't facts. Just because you feel it doesn't mean it's true. And again, it's impulsivity and desperation and urgency that really gets the borderline in trouble. If they don't act on their feelings and they give themselves some time and they get some objective response to what they're going through, they tend not to make bad decisions, which end up, costing them their relationships, their jobs, and then the guilt and self-hatred that follows, a self-fulfilling prophecy. So, the other label, or the other, the catchphrase I like to use with my patients with this cluster of symptoms is, it's really an illness of letting go. Very hard to let go. Obsessive thinking, very hard to let go of any disappointments, letdowns, criticisms, perceived, real or otherwise. And very hard to let go, if not possible, of partners. There's a well-known book written about this, and the book's okay. The title's fantastic. It's called "I Hate You, Don't Leave Me," and it's the paradox of this cluster of symptoms. That's kind of the feeling, having a partner that you can't stand, you pick at, yet you can't imagine being without.